Okay, I'd like to welcome everybody to the THN PCP Town Hall tonight, where we're going to talk a little bit about how to care for your patients and your practice at the same time. We appreciate you joining us and are so glad you're here. We're going to spend about an hour going through several topics. So Matt, if I could have the next slide, please. We're going to have this brief introduction that I'm doing right now. Then Dr. Grapey is going to go over some of the telehealth options that we've seen emerge in the last couple of weeks, as well as some payer coverage issues. I'm going to chat a little bit about helping your patients and helping your practice at the same time. And I'll also talk a little bit about some quality and RAF issues that are popping up here during the COVID-19 emergency. Dave will then return to talk about some medication adherence strategies, and then we will have Lauren talk about what THN is putting together for you. So Lauren Williams is our Executive Director for Plan Performance, and you may not have met her before. But most of the speaking will be by me and Dave. During that time, if you have questions, we would invite you to put them out on the chat function that's there. At the end of our time, in about an hour, we're going to have Dr. Reed kind of MC or moderate answering your questions to the best of our ability. And of course, as is usually the case, if we can't answer it tonight, we will try to get answers as quickly as possible. We are recording this tonight, so if you do have colleagues that have been unable to make it tonight, you can they will be able to access them on THN Learn. So once again, if you have questions, just put them into the chat or Q&A function there that you see on the WebEx screen. And we will get started now with Dr. Grapey.
Okay, you can go to the next slide, Matt. Good afternoon, good evening. First of all, just kudos to all of you providers and administrators who've been able to successfully stand up a telehealth solution or potentially many solutions in such a compressed time and under really such significant duress. And I think whether you are using a relatively straightforward app, something like FaceTime or Duo, a dedicated meeting platform like Zoom, or you're fortunate enough to have an EMR that has some integrated telehealth, the priorities are pretty much the same. We need, obviously, to address patients with acute needs, evaluate them and care for them while protecting your patient panel that has remained well through the crisis. Equally, protecting your staff, yourself, and ultimately your family. And then third, and equally as important, is making every effort to try to maintain revenue for the practice in order to stay in business. Now, I'm not going to go through a litany of telehealth options. Not only am I not an expert on this topic, I suspect the majority of participants on this call today know more about these platforms and some of the telehealth issues that I do. But I do want to at least pose some food for thought or an opportunity that this crisis is offering as we stabilize and get through some of these early phases. And you know, I've been on some webinars. I've heard of some practices that have been able to restore about 75% of their productivity. I had a call yesterday with a group that, you know, honestly does have their revenue through value-based contracting and capitation, so they haven't had revenue loss. But they impressed me with the fact that they have outreach to more patients and have had more touches in these last few weeks than they had prior using telehealth in an effective manner. And I think what I really want to leave you with is that this productivity really requires integration of not only clinical and administrative workflows, but the technology to meld all those together. And the easiest and most effective way to do that is through a comprehensive digital health engagement platform. And it's really becoming clear that the need for, and more importantly, the desire of patients to interact in telehealth is not going to go away immediately at the conclusion of this pandemic. If anything, telehealth was already making substantial inroads in lots of areas of medicine, some areas of the country more than others. But I think it's really vital that our practices start to develop and think about strategic opportunities in a way to remain competitive within this whole new emerging arena. And so I think that as groups get their footing and as telehealth platforms are operational and people are either getting by or thriving in this environment, then I really think it's time to consider looking at something that you see here on the right, which would really be an engagement platform, building a digital front door for your practice that is much beyond just telemedicine, but really offers the opportunity for scheduling either through your practice or by patients, reminders through text the way patients want it, secure messaging, um, digital forms that they can fill out encompassing all the things that primary care practices need, screening, there are survey capabilities, and even integration with wearables. Next slide, Matt, please. So as far as vetting and choosing a platform, I really have no great insight. I certainly recommend trusted peers, demos, reference calls, even consultants, all the same things that you did when choosing an EMR. There is some data out there on the website. I picked some telehealth platforms that were highly rated that seem to have a lot of reviews. And some of these are more simple solutions and some are more complex. And this is really just as an example of areas where you may be able to do some due diligence. Next slide. Next. So the one thing I do want to make you aware of is that Cone Health was in the process of contracting with RX Health when this COVID crisis hit. And RX Health has built a platform on Zoom, obviously with enhanced security and HIPAA compliance. And with this platform, in addition to telehealth, they're building things that I just talked about that really encompass an entire engagement strategy. Now, Matt Butala from THN has been able to help a practice or two at least vet some of the telehealth capabilities. This is a tough time to kind of start or launch a new platform, but I do know that Cone is going to be offering this to their practices, but part of the contracting is that they will have this opportunity for some of our independent practices to be part of this with obviously lower prices due to the nature of the contract. So we're happy to help you kind of vet some of this or be involved. And so that's part of what our mission and what our really goals are, is to be a resource and to help. And so certainly willing, Matt Butala can be reached out to help figure out whether this might be something like this might be right for your practice. Next slide. We also have really strived to try to have at least a central location for many of the resources on Triad Healthcare Network. If you look to the left side, there's THN Learn. Within THN Learn, we've placed as many resources as we can that really kind of more efficiently and effectively have links that go out to governmental and payer sites to be able to check on coverage. That was changing almost daily. Things have really settled down. And so we may be able to just build some matrices that allow you to really sort of see those things, but right now they're active links. It's not that great visually, but it does have the information there, and we'll be happy to announce that we do have a THN app, and so we'll talk about that a little bit later. Next slide. Essentially any Medicare service that could conceivably be done through telehealth is now covered. Now, the big caveat being that Medicare does require video capability, and for most health plans, audio will suffice under most circumstances. Next slide. I did want to point out that home health is also has opportunities to engage beneficiaries with telehealth, and we've worked hard at Health Team Advantage to be able to offer that service for our home health providers. Importantly, for providers themselves, the important thing to know is that the restrictions around homebound qualification really have been changed dramatically. And so if you have patients who have suspected or confirmed COVID, or more importantly, just have a medical counterindication, given the situation, to leave home, they can be considered homebound. And so you can institute home health for many of your patients. Next slide. So on our website, we have these grids, and on the right, and these slides will all be sent out to you. They are linked. So on the THN Learn, we have grids like this that do have the various payers, their policies, and most importantly, links where there needs to be additional information and also information that could be changing. AHEC has a very similar website that has excellent telehealth resources. There's also the through Medicare, the Medicare Learns website. So these three links you should be able to take and put on your computer or any place you want, so you have quick access to that. Next slide, please. Yesterday, I saw something come through from the North Carolina Medical Society, so this should be on our website, if not today, certainly as soon as possible, and then hopefully on the app. This is a 4-page document that goes through the major commercial and Medicare Advantage plans. Doesn't include Health Team Advantage because this was statewide and we're more local, but it does have information about reimbursement, the parity for it, cost share information, and so this also will be on the website to be able to be referenced. Next slide. So AWVs will be an important part of this presentation today. And so the good news is that AWVs are being covered by telehealth. And in general, as a caveat for Medicare, it does have to be video. Almost all the payers essentially are paying for audio only. If a member simply does not have technology or access, there are a few caveats. Blue Cross Blue Shield requires a little bit of a change in modifiers if it's audio only. At least last time we checked, United had not completely waived all copays, coinsurance, and deductibles. Most of the payers are covering essentially all the wellness visits other than the Welcome to Medicare visit, which Health Team Advantage is. And so this is, and certainly again, the references that we have will allow you to easily go and see what the most up-to-date information is. Next slide, please. And so I'll conclude this little section with just a few tips, tricks, caveats, things I've read. Some of this may be self-evident to you, especially if you're further along in your telehealth journey. These are some things that I saw on either various webinars, presentations, or on the internet for folks that are using FaceTime, using iPads, obviously registering those under a new account so that's not the doctor that's showing up, may protect some personal contact information. It's obviously critical that you have a process down to get patients signed up depending on what your app or portal is. Do they need to download something? There are a lot of nuances about whether a mic is turned on or a camera. I think it's important to have an alternative platform or strategy as these appointments are being made. If somebody's planning on being on FaceTime or we're going to use FaceTime and there's a Google phone that may not work or work well, and so always having your staff have a alternative, whether it's a phone call, which phone number is going to be most accessible. Frequently asked questions on the website for information and for marketing. Obviously being cognizant of what your office or home background looks like. We have heard that there have been members who are concerned about safety and security of virtual visits. So potentially a script either online or when those appointments are made around the safety and security. I saw some creative things around involving patients and caregivers in exams, especially on the pediatric side, where you can get a lot more information if you coach folks through that. At least one practice I know of that was converting walk-ins to virtual by using a kind of a safe room off to the side to try to keep those folks away from the main group and converting those to virtual visits. I think it's important to have some flexibility. We all want to have standardized work and standard processes. This is clearly a time where I think with providers and burnout that we allow providers to find at least initially, the platform or the work strategy that works for them as groups kind of come together and figure out the best approach across a practice or a larger enterprise. And then I think that the real caveat here too is that everything we're seeing is that the overwhelming amount of folks that have been touched or have had encounters through telehealth have been very satisfied and are very willing to continue to schedule all their visits. I think this is a sea change that is going to carry over, and I think is part of the motivation for considering plans and strategies beyond just getting through this current crisis. And with that, I think we'll turn it back over to Dr. Osborne.
All right. Thanks, Dave, for that quick summary. And again, we know that many of you already know that, but we wanted to give you a few tips and tricks that we've discovered along the way, and also review those resources for you for the payer information. So one of the things that we've been talking about at THN is that this episode of this epidemic and this episode in our lives where everything is turned upside down might give us an opportunity for practices to do some innovative stuff and maybe do some proactive stuff to both help their patients and their practice at the same time. Of course, many of you are doing various problem-oriented evaluation and management services and doing that appropriately, and some of those are routine. That you're able to contact patients and get them set up and then arrange for any, say, lab testing or something in your at your office or near your office. We have some innovative practices that are actually having drive-up blood drawing so that the patient doesn't have to get out of the car and come into the building. So there's all kinds of innovation that we can do. But the two things that we want to talk about tonight, next slide, really are two strategies beyond what I would call the 992XX or the problem-oriented E&M services that you should consider. And I'm going to tell you that some of you are already doing this and some of you are already doing it well. So some of this is going to be repeat for you, and I apologize if that's true. But we also have some information that I'll show you in a moment that indicates that not everybody is doing these visits and these services as robustly as they could. So we're going to turn first to annual wellness visits. And just again, by way of review, there are two types of annual wellness visits. There's the AWVI. This is the first annual wellness visit that's done in a patient after they have been on Medicare or in an MA plan for 1 year. They have to have been in the plan for a year. If you do an exam in that first year, it needs to be the Welcome to Medicare physical, also called the IPPE or Introductory Preventive Physical Examination. Then every other annual wellness visit that's done every year is AWV subsequent. Now the timing of this, I call it 11 months apart. Officially, they say 12 months apart. The point is it doesn't have to be exactly 365 days. It's really, they count the calendar months, and so you just, it really doesn't have to be quite 365 days for red, white, and blue Medicare. And the interesting thing about MA plans, most of them actually will allow you to do it anytime in each calendar year. So although one would not want to do this, one could literally in some plans do a annual wellness visit on December 30th and on January 2nd, and they would both be covered. Of course, that's somewhat illogical, but the point is, as long as they're in separate years, you're okay. They don't have to be 365 days or even 11 months apart. And of course, as most of you know, a problem-oriented evaluation and management service can be done at the same time, both in your office when we get back to those days, as well as by telehealth strategies. Now, not everybody does a great job of getting annual wellness visits done. And I'm going to walk you through this slide. The blue bars are the populations, and these are basically practices with in our next-gen population. And so we have practices that have just a handful of patients, and we have practices with multiple physicians that have almost 2,000 patients. But what I want to point out is that we have some practices that where 80%, and that's the orange, 80% of their patients get an annual wellness visit every year, and kudos to them, because there is good evidence that patients who get annual wellness visit have gaps closed better, have better compliance, and have better follow-up for all their healthcare problems. But notice that there's a fair number of practices in our network where it's quite low as less than 10% in a few practices. So this is, I think, an opportunity for you to think about how to use your staff to reach out to some of these patients to get this done, because your staff's probably not as busy as they once were, and you're trying to figure out whether you have to furlough them or reduce their hours or something like that. But here's an opportunity for you to get them on the phone, trying to contact people who have not had annual wellness visits if it's not something you've been doing regularly, and get them going. I'll return to that topic in just a moment. But first, let me just remind you what the content of an annual wellness visit is. Basically, it requires a thing called a health risk assessment, a functional let's see, a functional assessment and the measures of depression and fall risk, plus a couple of other things. So the big thing is this health risk assessment. And the health risk assessment is basically got demographic data related to various aspects of the patient's life, age, et cetera, et cetera. The self-assessment of their health status. In our annual wellness visit, we just ask people how do they think they're doing. And you get some really interesting answers that leads to some really interesting discussion after that. You need to think about psychosocial risk that they might be having. They have behavioral risks, alcohol, substance abuse, tobacco use as well, and both in the psychosocial and the behavioral risk. And you also have to assess their ability to get through activities of daily living and instrumental activities of daily living. In our practice, it's in this area that we also ask some of those important things that our patients are then queried on later about bladder control, fall risk, and stuff like that. So again, you need to include that in your AWV, your initial AWV. The medical and family history has to be listed. This is not an in-depth review of all the patient's medical problems. It's really just a listing of them. And you also need to take a list of current physicians and other providers the patient has and suppliers of various medical supplies, pharmacy, DME, whatever that the patient might have. And I will tell you, in my years as I was practicing internal medicine, there were many times I discovered that patients were seeing doctors that I had no idea they were seeing. You do need to measure height, weight, and blood pressure. We're going to come back to that from a telehealth point of view. You need to do something to assess cognitive impairment. It's not necessarily true that you have to do an entire formal screen. Just in your conversation with the patient, to the best of your ability, you need to figure out whether you feel like they're cognitively impaired. You need to review risk factors for depression. Most of us do that with a PHQ-9 or similar tool. And you need to review functional ability, their ability to ambulate and stuff like that. So again, this is the content that's necessary, and most of our practices actually use a form that the patient uses to fill out this and gets all the information in ahead of time or upon arrival at the office if we are in the office. And it does include a fall risk assessment of PHQ-9. Now, the annual visit subsequent has a little bit less content. You just need to update things from the past. Again, you're supposed to measure height, weight, blood pressure, come back to that. You have to detect cognitive impairment. Interestingly, you don't have to review the patient's functional ability or their depression, at least according to the regs, but most of us find that it's useful to do. And so many practices end up using the same health risk assessment, functional assessment forms, fall risk, and everything. Next slide, please. That they do in the AWVI. So we do use very similar forms in our practice to do that. So what are the deliverables after you have done an AWVI or an AWVS? Well, you need to provide the patient with some written materials, which in this case will probably need to be mailed or posted on a portal forum, where you list the risk factors for which they have for which you're recommending interventions, or maybe those interventions are already underway. You need to refer them for counseling and self-management and wellness if that's appropriate. And you also may think about advanced care planning. That is at the beneficiary's discretion. If you recall, when these came out a number of years ago, there was this whole discussion about whether we were trying to send everybody off to their death by telling doctors they had to actually discuss advanced care planning. Fortunately, the tone of that has calmed down, of course, and so it's a good opportunity to do advanced care planning, and there is actually, if you do formal advanced care planning, another billable charge for that. So many practices have pre-printed forms to fill out for the patient related to these. You just kind of check off the boxes and stuff like that. So then what can you do right now? Well, you could find patients in your population who have not had an annual wellness visit in over a year. And guess what? We can tell you all of those people if you want us to. And then have your staff reach out to the patients and try to schedule a tele-AWV. We think this is an ideal time to do it. You could, there are several ways that practices have discovered that they need to have, that they've discovered or they've used to have the patient fill out the HRA and the associated paperwork. You can send or email to the patient to fill out the forms, and they can return them to your office. They could use an EMR portal form. In some practices, we do know of practices that have third-party applications, but they basically have created a form, the patient fills it out, it uploads into the provider's EMR. And when push comes to shove, you could also just have the staff call the patient to go through the form with them. Honestly, some of our staff feel like they get a lot of more information from the patient when they actually talk to the patient and go through the form, because you'll get some little hints from the patient along the way, so that can be quite valuable. Then you need to have the visit by audio visual telehealth. Again, Medicare required, MA preferred, but they will accept audio only if they otherwise can't do a audio visual telehealth. And then they need to you need to send the patient the forms required as part of the A-to-B. And again, some practices have an opportunity to post that on their portal for the patient to get, or you could mail it to the patient. Now, the reason this is so good, first of all, is that it's good for both you and the patient is on the next page, next slide rather. And that is that here's the codes and payable and allowables for annual wellness visits. And there is no co-insurance on an annual wellness visit. It's 100% covered by Medicare and Medicare Advantage. And so we would encourage you to do these services. We think, again, this is a really good opportunity to help your practice at this very difficult time. So what about the blood pressure, height, and weight? There's been a lot of discussion about that. There is, in fact, no official word from Medicare about this. There are several lines of evidence and several people who have asked questions who've gotten some unofficial word from Medicare that you just have to do the best you can. Our opinion is that if you've seen the patient within the last 3 to 6 months, particularly if it's a patient in whom these measurements don't change over time, you can feel very confident in it. But we do recognize that there are some limits, and I think, again, I think as Dave was mentioning earlier, a lot of people are cutting some slack here for everything. So I don't think you're going to get in trouble if you use blood pressure, height, and weight that's reported by the patient. And of course, if you don't have that, then that's fine. And then that was how it's good for you. In this case, how it's good for the patient, you get to close quality gaps. Now, you know, some of these gaps are you can't close right now. You can't order a mammogram right now, but you can put them on the list for the future for a mammogram. You can't probably get a colonoscopy right now, but you could do a fecal blood testing with immuno testing if you wish to do that at this point. Of course, you can arrange for labs. You can do all kinds of other things. There's a number of things that people have determined that you can do in a annual wellness visit that close gaps, medication reconciliations. Again, we talked about the fall risk assessment, depression screening, very important aspects of what we need to be doing, arranging bone density studies when appropriate, and tobacco use and alcohol use screening. There is actually a separate billable code for alcohol use screening. It doesn't pay very much, about $12, but imagine if you had $12 more for every annual wellness visit that you do. And then don't forget RAF. We're going to talk a little bit more in a few minutes about RAF, but this is also a great opportunity to document those diagnoses that you otherwise wouldn't document, the presence of a colostomy, the presence of an amputation, something like that. These are great times to do that, because otherwise in the hubbub of our usual day where we're taking care of blood pressure and symptoms and diabetes and this and that, those are easy to forget. So hopefully you would find an opportunity to capture some RAF. So we think this is a great time, as I said, to think about a strategy to improve those telehealth visits so that maybe your practice could go from being down in the 30% range up into the 80% range. Now I'm going to turn to chronic care management. We talked a little bit about this at our last series of primary care division meetings. And there are, as I'll show you, several practices that do an outstanding job of that. But before I do that, I just want to cover the basics of this. And we had a lot of good discussion with various providers about this. But chronic care management is a set of services that is usually provided non-face-to-face. Now, it doesn't have to be. We do have models where certain clinical staff are actually having the patient come in to do some of their chronic care management face-to-face. So it's not a requirement that it be non-face-to-face. And it's not a requirement that it be visual telehealth. These are simply can be phone calls with the patient. So a very important point. So these set of services can be provided to anybody any Medicare patient or Medicare Advantage patient who's at risk for deterioration over the next 12 months. Well, the definition of that, honestly, is fairly simple. It's the presence of 2 or more chronic diseases or conditions. We recently reviewed this in our Eagle practice, and 75% of our Medicare patients have 2 or more chronic conditions. And actually, almost 40% of them have 3 or more chronic conditions or diseases. So really, there are a lot of patients out there that will qualify for this. The basic requirements to get started with chronic care management is a face-to-face visit in the past year. If you've not had a face-to-face visit in the past year with a patient, this would be a great time for a tele-annual wellness visit and discuss with the patient the need to get started with chronic care management. You do have to develop a comprehensive care plan. I'll come back to that in a minute. That's not something that most of us as providers are used to developing. In most situations, these are developed by nursing staff and others with an expertise in this, or use some model forms that are available. But you do have to develop this comprehensive care plan. It needs to be recorded in the chart, and you also have to provide a copy of that to the patient. And you have to have access to care 24/7 to address urgent needs. So that means somebody in your practice needs to be available all the time. Now, let me make a comment about that, because we have run into some practices in some of the smaller communities that have found it difficult to be on call by themselves. So it is not the case that you have to be on call for your entire practice in order to use chronic care management, but you have to be available 24/7 for the patients that you assign to chronic care management. So you might be able to think of an innovative way to do that. As this slide indicates, we got some practices that are really good at this. Again, blue bars are the number of patients in the various plans. This is across multiple MA and our next gen population. And you can see that we have we have practices that have up to 25% of their practices in chronic care management. So this is something that many of your colleagues have found to be very good. So what's so good about it? Well, the first thing is that it's good for patients. And the next slide will show you that some Medicare data Matt, next slide, that revealed how beneficial this is for Medicare. Oops, back one. I hope. Can you go back one, Matt?
What are you seeing, Jim?
Maybe. I'm seeing, that's what I need. CCM is good for patients. Thanks. That's good. I'm seeing the arrow. Sorry. All right. Mine had gone to the next slide, so sorry about that. Okay, so CCM is good for patients. Here's some very interesting data that was published by Medicare last year. This is the difference in cost on a per beneficiary per month basis for patients who had chronic care management. And the line in the middle is actually the control group. Okay, so if you see something below the line, it means that it is lower cost than the control group. And if you see something above the line, it means it's greater cost. The dark blue is the 6-month follow-up period. The light blue is 12 months, and the kind of turquoise is 18-month follow-up. And what's interesting is that the patients had a steadily decreasing amount of inpatient hospital services. They had a steadily decreasing amount of skilled nursing facility services, and increasing use of home health services, and a decreasing use of outpatient services, radiology, and surgery. But look, increased professional services. And the thing that was very interesting about this is that it was not the case that the patients getting chronic care management stayed out of the office. They actually came to the office more to see their primary care physician. So not only was there benefit from the point of view of chronic care management and the billings that can occur from there, but also increasing numbers of office visits. And there's at the far right, the effect of total Medicare expenditures. So although the cost went up in the first 6 months because of the cost of the program, it actually dropped by $28 in 12 months and $74 per member, per beneficiary per month within 18 months. That is a 10% decline in cost. We have $300 million or more, we actually have more than that probably, of Medicare costs going through THN. If we lowered that by 10%, it would be pretty overwhelming. So again, something that's good for patients. Next slide indicates that it's good for practices as well. These are the Medicare allowables that exist. So CCM, which is 20 minutes or more of time spent with a patient per month, is $40.50. This year, there's a new code called G2058, and this is when you have more than 20 minutes. So if you have 20 extra minutes after the first 20 minutes, you can bill $36.42, and if you have a second 20 minutes after the, if you have a third 20 minutes after the first 20 minutes, you can bill another $36.42. There's another thing called complex chronic care management, which is really a matter of complexity of the patient. I'm not going to go into great detail with that, but there you get paid for over 60 minutes per month and multiples of 30 minutes. So these are things that can be very profitable because the people providing this service is not you. You're not the person providing this service. This is being provided by your clinical staff in your office, practicing up to the limit of their license, whether that's medical assistants helping patients manage their care, or nurses, or LPNs, or pharmacists, or whoever. These are people that are supplementing what you do, and so this isn't something that is requiring your full attention. It's not your 20 minutes that you're billing for, it's the 20 minutes of your staff time. What about copays and coinsurance? Next slide. That's a big question that many people have because when you talk to patients about this, you have to get their permission to do it. And sometimes you have to, they're going to ask you, how much am I going to have to pay? Well, the good news is that for the THN contracted plans, the only Medicare Advantage plan for which there is a copay required is Blue Medicare. Every other plan has a $0 copay for chronic care management services. One of the hardest things, though, is sometimes when patients have Medicare and a supplement. And I know this is small, and you might not be able to see it very well. But basically what I'm trying to show here is that almost every supplement pays 100% of the Part B coinsurance. There are, I don't know if you know this, but Medicare supplements have to have a letter. So there's A, B, C, D, F, G, K, L, M, and N. And what you see, and by the way, Plan F is kind of the Cadillac plan. That is the one that people often call the Cadillac plan because as you can see, basically everything is covered up to 100%, including the deductible. But what happens here is if you look at the second line, it says Medicare Part B coinsurance or copayment. That means if it's 100%, that means the Medigap supplement, Medigap plan or the Medicare supplement plan is paying 100% of the cost. Now for Plan N, you see those three asterisks there. What I don't have on this chart is they do have to pay their deductible, which is $198 per year, before it is covered 100%. And it's only Plan K and Plan L that have 50 to 75%. You can look at a patient's Medigap card, and it has to tell you what letter plan it is. So this is a really good thing. This is something where patients do not have much out of pocket most of the time. Of course, if your patient has Medicare without a supplement, they will have to pay 20% coinsurance, as they always do. So what do we recommend you do? Next slide. We think this would be a great time to reach out to your patients to get them involved in chronic care management. As I've said, many patients with Medicare and MA in our Medicare population, both regular Medicare and Medicare Advantage, have 2 or more chronic conditions that could lead to clinical deterioration over the next 12 months. This is just, again, a great time. Your staff is probably not as busy as they were. Again, trying to track down these patients, we have discovered that many of our patients are answering the phone like they never have before. That does make us worry about that a little bit. They may be susceptible to people that may prey on them. But the reality is they're going to answer the phone because they want to talk to somebody. And so this would be a great time to reach out to them and get them involved and then continue to have them involved as they go forward. And the real value of the care plan, I have to tell you, is that it forces the care team, that's you and your staff, to assess and explore things besides the medical conditions that can lead to deterioration. And these are, as you know, the social needs of the patient. Whether a patient can get to the pharmacy to get their meds, whether they have food and stuff like that. And all of these are amplified during the COVID-19 crisis. So this is a unique opportunity to reach out to patients, to serve them well, and to serve your practice. So I hope you'll be thinking about the possibility of adding tele-annual wellness visits and chronic care management to your practice and implemented it to a greater degree if you are already doing it. And we hope that it will be successful. And we'll talk about some tools at the end of this session that we have that might help you with that. I did want to turn for a moment and talk about quality and RAF during the COVID-19 crisis. Next slide. CMS announced last week that they are no longer going to require submission of HEDIS data or CAHPS survey data for 2020 stars. And that got everybody really excited because they said, see, CMS is not going to worry about quality metrics for 2020. Not quite true. There's also another possible myth, and I got to say this one is still not resolved completely, and I mentioned it earlier, and that's whether diagnosis codes submitted by telehealth for problem-oriented E&M services and annual wellness visits are going to count for RAF. We'll go through both of these. The first myth is that CMS is not going to worry about quality metrics. As I said, they announced last week that they're not going to require submission of the HEDIS data and CAHPS data. Next slide. But I need to walk you through something for you to understand this. On the far left, you see, on this chart, you see measurement year, then you see various cut points published, the resulting star rating for that plan, and the effect on MA plan revenue. And so the key here is that if you look at measurement year 2018, that data was reported to CMS in early 2019 and into about June of 19. Cut points were established because of the data in 2019, and that resulted in the star rating for the plan in 2020. So in their advertising, when United Healthcare said they were a 4-star plan in 2020, this year, that was actually based on data from measurement year 2018. It will affect their revenue next year. 4-star plans get a 5 to 10% bonus per member per month, depending on whether they're in a double bonus county or not, and we are a double bonus county. But now, when they said that we are not going to collect any more data for HEDIS 2020 or CAHPS 2020, these are really results from measurement year 2019. So during this first half of the year, Medicare Advantage plans have been scrambling to collect these last few pieces of data for 2019 to submit. And what CMS is saying is you don't have to do that anymore. So in reality, they are not telling us anything about 2020. In fact, next slide, what they told us, what was published in the same thing, is that it's too far along, I think. What they told us is that the measurement year 2020 results will actually determine the 2022 star rating. So here's our question at THN that we don't have, we don't know yet what is going to happen. Measurement year 2019. Well, let's look at measurement year 2020. All right, that's what we're in right now. What CMS is saying is that the star rating for 2022 for an MA plan is going to be determined by the data that are collected in 2020 that will be, the performance of the work done in 2020 with the data collection in 2021, and then the cut points announced in 2021, and again, the resulting star rating for the plan in 2022. But our contracts are kind of interesting because our contracts, almost across the board, for a measurement year, we're held accountable to the cut points that's published the same year, not the next year. All right, so we actually use the cut points from last year's measurement year to determine how we do on our plan. So as we've announced before, THN is excited to be 4.26 stars in our United Healthcare Medicare Advantage lots, which was really great because that was an extra $3 million for THN to head down into our physician incentives. But the reality is that that performance in 2019 that led to that, when we said we're 4.26 stars, was actually based on cut points that were published in October of 2019. So that's a long way of saying the following. We are going to need to focus on quality. Even though it's hard right now, even though it's difficult right now, we cannot let ourselves off, can't let ourselves not keep focused on it. Because basically the quality that we do, the quality of care that we deliver here in 2020, despite the COVID crisis, is going to determine, for instance, for our Health Team Advantage colleagues, a large part of their 2022 star rating. And in addition to that, we will be up against last year's how do I want to say this? Last year's ratings, last year's cut points, to try to figure out where we are. So again, we've got to concentrate on quality. Now, the next thing I want to talk about is the possible myth I was talking about, and that is whether diagnosis codes submitted by telehealth mean anything. Now, it is a true statement that in general, it is true that risk adjusting factor codes that are diagnosis codes that are submitted through the former telehealth codes do not risk adjust. But United Healthcare Medicare announced last week that they think that the diagnosis code submitted for a problem-oriented E&M or an annual wellness visit done through telehealth will count. We have been lots of discussions with CMS. There's no official word for it, but we think they will probably agree with that, because of course, as you can imagine, if they don't, the RAF scores are just going to plummet for everybody, and all the diagnoses are not going to be captured as they should be. So in conclusion, just to remind you, we have to focus on quality to the best of our ability. We have to continue to submit properly assessed and documented diagnosis codes to payers, even during this time of the COVID crisis. So speaking of quality, I want to turn it back over to Dave to talk a little bit more about med adherence.
Thank you, Jim. And before I do that, I just want to add a little addendum to what I spoke about earlier. After I completed that part of the discussion, Dr. Jenkins, emailed me with, I think, some information that I think would be valuable to the participants. And John is now an instructor in digital health and practice improvement with AHAC, but I know him as being really expert in telehealth and all things digital. And he and the AHAC team have partnered with North Carolina Department of Health and Services to offer some educational programs around telehealth on Monday mornings or Monday afternoon between 12 and 1. Featuring some tips, operational guides, visits to focus on, and some case studies of some successful practices. And so that can be accessed through the AHEC site. I'll ask our practice performance specialist to put a link to this on the THN website and the app as well. He also mentions that DoxyMe is offering some very special deals, and that site will offer some additional information. So thank you, John, for providing that. Matt, next slide, please. So really just briefly want to discuss about telehealth really to advance med adherence. Now, Jim talked about annual wellness visits as a entree into complex care management. And I think this also is an excellent opportunity, to the best of our ability, to impact med adherence, understanding, of course, that there are a lot of factors, and we only have so much control over that. I mean, annual wellness visit in itself is obviously extremely valuable. It's valuable for the member to get gaps closed and a number of issues addressed. Certainly the THN, especially as gaps get closed and codes get placed on claims. And then for providers, it is one of the services that does pay better than many. And I'll remind folks that Health Team Advantage does pay 130% for annual wellness visits, which makes it even more valuable service with regard to revenue, especially in this time. Next slide. The importance of med adherence, I think, is really illustrated on this slide. Now, within our value agreement on the traditional Medicare and the next gen ACO, pharmacy quality really has almost virtually no impact. On the Medicare Advantage side, however, Medicare Advantage plans have star ratings which are heavily weighted towards Part D and mostly the med adherence measures, of course, which are all triple weighted. Because Medicare Advantage plans want their incentive plans to parallel what they're being judged on, the way our value agreements across our Medicare Advantage plans in our community are set up, well over, in most situations, well over 50% of our overall contract performance is determined by these Part D measures, specifically around med adherence, both the triple weighted MAH, MAD, MAC, but also around SUPD, SPD. So it goes without saying that if we're being held on our contract performance overall in THN on these measures, that it's really important that our incentive plan really parallel that. Now, I don't necessarily agree with the overemphasis on med adherence. I think that to have, as much as 60% almost of your quality determined by this makes little sense when you look at the totality of things that are important in managing a patient. But this isn't really our decision. And as long as this weighting exists and our performance was really dependent on this, then we really have to steer our incentives towards the same alignment. So next slide, Matt, please. So I'll remind the primary care providers that the 2020 PCP incentive is very similar, but there are some changes relative to historic incentive plans. Overall, 75% of the available incentive through our baseline incentive and our full margin incentive for primary care is allocated to quality gaps closed. But these quality gaps are also weighted. So if a med adherence gap is threefold weighted on a star measure, then it's also threefold weighted on the incentive plan. And in addition, new to 2020 is a scale which also provides a higher performance rate for providers, or excuse me, a higher score for providers who are able to close a higher percentage of their overall quality gaps, such that if you're extremely high performing and can close greater than 95% of the quality gaps in your panel, then those points will be worth 3. And if you have lower performance, and there's quite a few ranges in the middle, these are just 2 examples, then if it's under 65%, then a gap closure is worth 1 point. And really the bottom line being that triple weighted quality measures have a huge impact on what a provider can ultimately hope to gain on the primary care side through the THN incentive bonus. And again, simply because that needs to align in parallel with how our performance is across the Medicare Advantage plans. Next slide. So med adherence reports have been sent to the practices with data from 2018 and 2019. Looking back historically at how your panel has done through these years to see if they've had, persistent issues in one or multiple of these categories. So this will give the proportion of days covered or their adherence rates across the 3 main adherence categories, looking at both 2018 and 2019 data. Chronic indicating that they failed 2 years in a row, and there are some members who are triple fail. Obviously, evaluating patients who chronically fail med adherence to determine whether if they have barriers or issues with taking medicine, whether it's maybe not even worth prescribing in the first place. But in any event, these reports come with this guide, which helps understand the best way to make this actionable, at least has the patients, the practice, and then that is subdivided by the primary care provider, and then has the list of patients by payer, along with date of birth, so hopefully these members can be relatively easily identified. Next slide, please. And the other thing that we've really learned, and I think from our own review of data, but also from some investigation within the THN database, there is quite a bit of evidence that a 90-day supply does improve med adherence. So Jim Osborne had the analytics team look at one of our MA plans and looked at adherence rate overall for members who were getting 30-day fills versus 90-day fills with a significant difference. I've seen this across several other MA reports. I've asked our analytics team to run this for a couple of other payers to see if it is consistent. I was also able to find data in the literature that this is true in Medicaid populations and for some less traditional, the med adherence, but looking at just general med adherence after acute MI. So I think across a lot of different adherence data, there's evidence that 90-day does make a difference for adherence. Obviously, one of the problems with this whole thing, if they're getting these prescriptions filled, it doesn't mean they're necessarily taking the medication. I understand that, we all do, but it's obviously the first step. As Jim pointed out too, and in most primary care practices, it would be very typical that these medications are refilled on most established patients by a medical assistant. So as much as you can share this information or change workflows or strategies within the practice such that this is communicated down to the people who actually do this. Next slide. And that concludes that, so I thank you very much.
Okay, and I think I am up next. This is Lauren Williams. I'm the Executive Director of Health Plan Performance, and that encompasses the RAF team, the quality team, and also the practice performance team. Next slide, Matt. And I'm going to talk a little bit today about some of the ideas that we've come up with that we hope will be helpful to your practice. So our practice performance specialists will be reaching out to you to see what you need. We obviously want to hear from you as well, but we've got a couple of things to share tonight. One of those is the THN app, and like a lot of things recently, this slide is already outdated because that app is actually available now as of today. So it is available for both Android and Apple phones, and I'm going to let Matt make a couple of comments. He is the individual that got the contract in place and got this app developed and really pushed to get this done so quickly. Matt, you want to say a few things?
Yeah, sure. Thanks, Lauren. As Lauren said, both apps are up and running and available on the Android and app stores, and you just need to go in and search for Triad Healthcare Network. Get those downloaded. You don't need any kind of a password or anything. These are available for the public, for our providers, for your office staff. What we're trying to do, we intentionally made this easy because we know that sometimes you're getting things and it's cumbersome to get through THN Learn even. One thing I would impress upon you is to make sure when you first sign up for the app, it's going to come up and ask you to allow push notifications. I promise to not bug the crap out of you. I'll only do a push notification when it's something that would be super helpful to your practice. And if I'm not doing that, then I would also ask you to hold me accountable and give me some feedback. The other thing too, the directory part of the app, I made this a place where you can find your practice performance specialist very easily. Right now, all you have to do is go up into the search function, and if you're a primary care provider, you start typing your primary care group, and it'll show you who the PPS is assigned. It'll give you their email address and cell phone number. And then if you are having any troubles with a specialty, or if a specialty provider happens to be on this webinar, you can also just type your specialty or type a specialty, and their assignment will be there too, so that you can get to the right PPS to help any specialty needs that you might have. So really excited about it, and I hope it's something that's helpful. And again, I'll take any feedback that I can get, because the goal here is to help you. So thanks, Lauren.
Great. Thank you, Matt. Next slide. So I mentioned that we have been meeting internally trying to come up with ideas that we think might be helpful to the practice. Obviously, again, we want to hear from you, but these are some of the things that we've come up with. First one is supplies. Can we be the individual that does some of the legwork for you? Can we try and find some supplies for you? Matt, for example, has come up with some face shields that we are willing to give to the provider offices, and we've got a pretty limited number of those. But if there's things like that we can help with, we certainly want to hear about it. We also want to look at best practices. So we want to share what we're hearing, and we also want to hear what you're doing. So one of the options is to connect you with a provider office if there's something that you're struggling with and they're doing well. So we're certainly open to that, and just reach out and let let us know what you're struggling with. We can also offer scripting and process flows for some of the things that we've talked about tonight that might be new to your office. So for example, if your team has not normally done patient calls for med adherence, we can help with that by giving you the scripting. We've also got some COVID-19 reminders that might be helpful if you want to have those scripts as you reach out to patients. Couple of the other things, we are willing to do outbound calls to your patients, obviously with your permission. So we would certainly get specific instruction from you. But some of the things that we have kicked around are doing some COVID-19 reminders, maybe remind your patients that they can get early refills on prescriptions with some of the COVID-19 guidelines that are out there. So pharmacies will now allow patients to refill their prescriptions early. We could also potentially look at helping you schedule some procedures later in the year. So for example, could we go ahead and schedule a mammogram in September or October for some of your patients? So we're willing to do those kind of things, and then also help with the gap closure if you're not doing some of the things that we've talked about tonight. So if you need somebody to do some med adherence calls, talk about fall risk, maybe flu vaccines, we've got a team in place that can do that. We also are working with LabCorp, so if you would like us to do some direct mail to your patients for things like A1Cs, FOBT kits, or nephropathy screening, we can do that as well. Obviously, we need your permission for that. And if we're going to be doing those kind of things, we would like to work with you on some standing orders so we don't have to bother you every time we come across a patient that needs one of those tests. But Matt and his team will be reaching out and can walk you through exactly what that would look like. We have also done some Emmy campaigns for a couple of groups recently that have requested it. So we did a COVID-19 Emmy campaign recently for CHMG. If other teams are interested in running that campaign with your patients, we can do that as well. We can provide you with the scripting for that so you know exactly what they're telling your patients. Typically, it's things like reminders on safety, hand washing, social distancing, all the things that we're hearing over and over. But we can also provide some food resources for your patients and also some medication delivery options. So we have a list of all the local pharmacies in Greensboro that will deliver medications to your patients, and we're happy to provide you and your patients with those resources. One other option is using an external organization that would do telehealth home visits. Again, this would only be upon your request. So we've got a group of patients that don't have a PCP currently. So we are working with some external organizations to have them do telehealth visits. But if you have some members on your panel that you would like to have a home visit from one of these organizations, we can offer that to you as well. Next slide. Some of the other resources that we've put together, and several of the folks have mentioned it previously tonight, all of these things will be available in multiple locations, the app and also on the THN website. But coding and insurance guidelines on telehealth visits. So we've got some very specific information on what codes you should use, whether or not you need a modifier. We've got the information based on the particular insurance plan. So some great resources out there. We are working to keep those current, so make sure that you always check for the latest and greatest version. We also have some RAF coding tips on COVID-19. So what are the actual codes that you would use for a COVID-19 diagnosis, as well as some of the other tips for RAF-related services right now with everything going on. We've got some resources from KPN. We had the town hall last week where we talked about how you can get some monetary assistance through the government programs. And so we've got some resources that can help you with that as well if you weren't able to attend the town hall last week. Again, I mentioned the referrals for food and pharmacy delivery. We've also got med adherence information out there as well. So quick reference guides, some scripting, some workflows that you could use in your office. And then obviously the gap reporting so that you know who needs a phone call related to med adherence. And a metric guide on all the 2020 quality metrics. So those are some of the things that we've come up with. If there's another resource that you're struggling with and you would like us to do some research and try to put that together for you, we're happy to do that as well. Next slide. I think that's it for me, but yes. So please don't hesitate to reach out. You can reach out to Matt directly, and that is his cell phone number, or you can always reach out to your practice performance specialist. You certainly can reach out to me as well, and we will do what we can to help you. And if it wasn't on the list here, please ask anyway, and we'll see what we can do to help. And that's it. Thank you.
All right. Thank you, Lauren and Dave and Matt. So just a couple of concluding remarks before we get to our Q&A. What we're trying to do tonight is quickly review some stuff that related to telehealth. We really want to encourage this idea of involving or getting patients set up for annual wellness visits to your favorite telehealth platform. We think chronic care management is a unique opportunity now to reach out to people and to get them involved in that, and then have them understand the quality that's reflected by having you reach out to their office on a to their home on a regular basis, so they don't have to always just reach out to you. We have talked about the importance of quality and RAF and med adherence. We've shared with you the exciting news that we got our app up and running, so that's pretty exciting, and that will improve over time. We just wanted to get it up and going as fast as we could. And then the other thing is that I just want to reiterate, we meant to put a picture of these up, but Matt's father was able to arrange for a technical school to create some face shields. And so we do, if your practice needs some face shields, some really cleverly constructed face shields that basically use that old transparency paper that your professor in college used to show you overheads, then they can certainly do that. And he can help you with that if you have an interest, so let Matt know, as we've already indicated. So at this point, we want to turn it over to Dr. Reed and let him be ready to guide us through any questions that have come up.
Thanks, Jim. So thank you very much. We all did a great job, and it's so thorough. I got to tell you, at this point, I only have 2 questions. They're excellent questions, but I mention that because any of you out there that were thinking of questions, and maybe you could submit them in a little while, now's the time to submit them, because we're only going to have 2 for right now. First question comes from a provider who asked about which Medicare products will cover AWVs when they're done using audio only. And Dr. Grapey, I believe you addressed some of that in your talk, if you want to handle that one.
Yeah, so I mean, it's really fairly straightforward. Medicare, traditional Medicare, red, white, and blue, requires video for a wellness visit. The Medicare Advantage plans, to my knowledge, and all the ones I've seen, will accept audio only. Blue Cross Blue Shield, there are some nuances. Blue Cross Blue Shield does want, in addition to the place of service too, for telehealth, a CR modifier if it's audio only. Otherwise, and United, I'm not sure they have waived all the copays or not, but the Medicare Advantage plans, the major ones in our community, will accept audio only AWVs. And if somebody knows different than that, please put it in the chat.
Dave, I would agree with that. The only thing I want to comment on is that there is no copay for an annual wellness visit. United Healthcare has not waived their copays for problem-oriented E&M visits, but they don't charge a copay for an annual wellness visit.
Yeah, that makes sense. Thank you.
Yep.
Good point. The other question I got came from a provider who mentioned that he's been hesitant to recommend CCM to his patients because of concerns of saddling them with copays. Dr. Osborne, I know you've heard that question several times before. Could you address copays with regard to CCM? And I also would point out that Dr. Beth Hodges is doing a great job in this as well. She's on this panel. If she has anything to add, I certainly invite her to do that as well.
So for our Medicare Advantage plans, basically this is a primary care service. And so basically, with the exception of, I'm beginning to get it, it's late tonight, I'm beginning to get it confused. So Beth, correct me if I'm wrong, with the exception of Blue Medicare, yeah, I'm pretty sure, yeah. With the exception of Blue Medicare, all the MA plans will cover CCM without a copay. And then for Medicare, again, it's all up to whether the patient has a supplement or not. If the patient does not have a supplement, they have to pay 20%, which is true for every Part B service that they do, and Part A service for that matter. Medicare covers 80%. If they do have a supplement, a so-called Medigap plan, as I indicated in the previous chart, and these slides will be available, as I showed in that chart, virtually all of them actually covered at 100%. You can look on the back of the patient's Medigap card or supplement card and find the ladder and look at the benefits and to see what they are. Beth, did I say that right?
You absolutely did. Good job, Jim.
Good. Thank you. I was afraid I was getting it confused when I started talking. Thank you.
I would also like to add that having been doing chronic care management for several years, I can only think of 2 patients that ever dropped out due to the copays. And that was more of a personality issue. They really are very receptive, and over time the copays, as Jim mentioned, have dropped off. But even when they were present, the patients felt that they got enough value that it wasn't a significant barrier for them.
Great comment, Beth. Thank you.
There is one additional question that's coming. A provider's asked about the alcohol screening that you mentioned, Dr. Osborne, and if this is covered by all Medicare plans, and if there's any copay involved. And the provider asking that question is speaking to you now, so I wanted to know.
Okay. To whoever that questioner was out there, I don't know about the copay. It is a Medicare covered benefit though. And if it's a Medicare covered benefit, then it must be a Medicare Advantage covered benefit. So it will be covered by all Medicare Advantage and Medicare and regular Medicare. To be honest with you, I don't know what the copay is on it. If it's only $12, I'm thinking there's probably not anything, but I don't know that for sure. So we can do some more research on that. Good question.
Didn't mean to try to trip you up there. I was really asking because if we do an AWV and there's no copay for the AWV, but we add that on, I didn't want patients to suddenly get a little additional copay, even if it's small. But thank you for finding out more about that for us.
And that's a great point, Rob, to comment. If you do a problem-oriented evaluation management service and an annual wellness visit, there is the possibility that would create a coinsurance or a copay. But again, all of our Medicare Advantage, almost all of our Medicare Advantage plans in Greensboro have a $0 copay for primary care visits. So it's not going to be very common that pops up. But I'm glad you brought that up, because while the annual wellness visit does not have coinsurance or copay, of course, a problem-oriented E&M service, a 992 XX service, as I call it, would have a potential copay. But again, we're fortunate that the competition among our MA plans here have led them all to make that almost always a $0 copay.
Excellent. That sounds good. At this time, there have been no additional questions. Right. Again, I think that's because of the thoroughness of the presentation. Really well done, all 3 of you all. So, Jim, I'll turn it back over to you.
Okay. I'm actually seeing a couple more that just popped up, to tell you the truth. One provider asked about whether there was going to be any leniency in the closure of gaps because of things like diabetic eye exams and stuff like that. To our knowledge, no. That was the point I was trying to make. We have to do the best we can despite the difficulty we have. Interestingly, Medicare is expecting the cut points to drop for 2020 that will be reported in 2021 that will result in star rankings for plans in 2022. So they are actually already stating that they're expecting a drop. So we have to do the best we can, and you know, that's the cards we've been dealt this year.
There's a question about templates for CCM. Yeah. Go ahead. Go ahead and address that.
I couldn't hear it. Sorry, go ahead.
Actually, a question just popped up about CCM for specialists, and it faded away before I could get the whole question. Unfortunately, it didn't stay.
Okay, so that has to do with a thing called there's chronic care management, and then what I'm blanking. The rest of my panel. What is the there is one that's available for specialists now. Might be specialist care management. I'm not positive. I can't remember. That is a code that is available for usually for specialists to use, and it's a little more limited, and it does require more provider interaction. Having said that, it is important to note that in their chronic care management, a specialist can provide chronic care management services and bill for them, but only one provider can bill for chronic care management services for a patient. So the patient has to sign up, and one of the things that you do when you're getting consent from the patient is you have to ask them whether they're getting chronic care management services from anybody else. And Beth, I might ask you, have you ever had problems with that since you have extensive experience with CCM?
Never.
Okay.
If I might add, traditionally CCM likes a assigned consent. So previous to COVID, we had always enrolled patients in CCM during an office visit. You will find if you, number one, this year, if you enroll them during an office visit, that enrollment reimbursement, I can't remember the code off the top of my head, but there's a special code that you use the day of enrollment. That will get denied by most MA plans. They will either pay that and not pay your office visit, or they will pay the office visit and not pay the enrollment code. So I do recommend that you actually submit the enrollment code on a different day than you do an office visit. But my real point in mentioning this was you can enroll people over the phone currently. So you can do a verbal consent. It does not have to be written.
Yep. So again, we're not aware of many specialists trying to do chronic care management. It really is something that's intended for primary care, but it is possible for specialists to do it. So that is a possibility. So there was another question about guideline templates. There's actually, in terms of templates of care plans, there is a website that we have used called the Michigan Care Management Initiative that has on its website a number of generic care plans involving a certain number of chronic diseases. I know within our EMR, there's a care management platform that's got care plans as part of that. And I know that Dr. Hodges has a separate program that she's used to try to help her staff create the care plan. So there are various ways that can be done in the area. So there's ones you can find online, although those are difficult. That's why I cite the Michigan one. Some outside resources as well.
Okay, I don't think I've seen any additional questions pop up. unless maybe you did, Dr. Osborne. But
Nope.
all right.
All right. Well, we're right toward the end of our time. Yeah, thank you. We're right here toward the end of our time. We want to thank you for your work in these difficult times. We know it's hard. We hope that you are each taking some time, hopefully every day, to take care of yourself. These are extraordinary times, and I know you've heard that a million times and thought it a million times, and it's still true. So thank you for everything you're doing for our community, for our patients, trying to keep your practices going. As Dave mentioned earlier, and Lauren, we want to do everything we can to support you, so reach out to us if we can be of any benefit. So with that, I'll say thank you again for attending, and good night.